Welcome to another episode of Meet the Leader. And today we have with us Dr. Sheth, an assistant professor and head at Advanced Genomic Technologies Division, FRIGE Institute of Human Genetics. Thank you, sir, for joining us today.
Thank you so much.
And it's honestly a pleasure having you here.
Pleasure's mine.
All right, so again, we have a situation whereby we have this trending word, cancer.
Yeah.
And I think everybody is kind of fixated on it because, it's something no one wants to hear, especially as a diagnosis or in any sentence whatsoever, whether it's for family or whether it's for self. But now I would like to ask, how do you see the variation in identification and expression of cancer, and how can they be categorized widely?
All right, so this actually goes more into the biological side of what happens in cancer. So initially, when the cancer diagnosis took place, it was more akin to where in the body is the cancer happening. So is it your brain or lungs or heart or bone or colon or wherever it is? And that is how cancers used to be categorized. And the treatment for majority of them used to be very, very similar. Essentially, you're going to a shoe shop and the shoekeeper is saying, I only have eight number size shoe.
Yeah.
You wear, you come back tomorrow and see if it fits or not. But of course, the world is slowly changing these days.
Yeah.
And the change has led to not classifying tumors or cancers by where they are occurring, but what sort of genetic mechanisms or variants, mutations, whatever you'd like to call them, are leading to the formation of cancers. And what you're identifying is that for majority of these cancers, almost similar mechanisms are at play. Ergo, the treatments or targeted treatments, as they're called these days, can be used to work on those mechanisms and stop cancers on the track. I'll give you an example. So, olaparib, or what are known as PARP inhibitors, are generally used to treat breast cancer because you have mutation in BRCA1 or BRCA2 gene. But it also occurs in ovarian cancer. So olaparib could also be used to treat ovarian cancer in this case. Another very good example is microsatellite instability. So that's the sort of marker that tells whether the the ability of the DNA to repair itself is working or not. It's kind of like a spell checker mechanism you have in your phone. If you mistype, then it gives you an error saying, hey, here is the word you wanted to write. Your DNA has that exact spell checker mechanism. So if it goes haywire, you generally get cancers of the colon or endometrium or small intestine or esophagus, stomach, liver, and pancreas. So all of these different cancers could happen if this one mechanism is failing.
I'm sorry. Is cancer the check sign or?
So the cancer is happening because this mechanism isn't working. Because this mechanism isn't working, you're accumulating mutations as you're going along.
Okay.
And the more mutations you accumulate, the more aggressive the tumor becomes as it goes down the line.
So essentially, it's how Indian traffic is without the warden at the directing at the end of the day.
Well, in a way, yes, and it's not just Indian traffic, if I might say so. If you go to many parts of the world, it's a similar issue. But in some sense, yes, that is how it is working. And there is one drug, it's known as immunotherapy. What it does, it primes your immune system to say, if any cell is having this particular mechanistic issue, go and target it.
Okay.
It's kind of like putting your immune system on steroids. And a lot of cancer, solid tumors in all of these different organs can be treated with this one drug. So rather than classifying tumor based on where it is occurring, you classify tumor based on which mechanism has gone faulty.
Okay.
And you provide treatment accordingly. So this is how there has been a paradigm shift in thinking about cancer and its treatment.
I feel like this kind of reminds me of when the car is having a problem and then just go to the mechanic and he's trying to point out to you 1,000 things that might be wrong, and missing one, that leads to another problem. And I think that kind of relates to the mutations you spoke about that kind of accumulates over time.
Yeah.
But then beyond identifying chromosomal abnormalities, how could genetic engineering be used to develop potential therapies or interventions for couples with recurrent pregnancy loss?
So this is us moving away from cancer. So repeated fetal loss, it doesn't sound like a big issue, but actually it is. a lot of couples, if they're having a child for the first time, nearly 30% of them will face abortion. A spontaneous abortion or miscarriage happens in the very first trimester. So essentially, the pregnancy has started, but within the first 3 months of the pregnancy, for some reason, the pregnancy aborts, the child aborts. And if that happens 2 or more than 2 times successively, this is known as repeated fetal loss or recurrent pregnancy loss. A problem that's very, very common, in fact. And in nearly 4 to 5% of the cases, in fact, it was Dr. Fanny Sheth at FRIGE Institute of Human Genetics way back in mid-2010s. She published one of the largest papers from India. This was on nearly 2,000 couples. And she showed that in 4 to 5% of couples having this issue, you would have a broad-scale genetic defect. So essentially, your chromosomes, which are big chunks of DNA, they shuffle about kind of like a deck of cards. So rather than having a nice, uniform, linear piece of DNA, bits have shuffled around. And because of that, when that faulty piece of DNA goes from either of the parents to the child doesn't have a full deck of cards. It doesn't have the full set of DNA instructions to grow. And because of that, it leads to repeated fetal loss. But now, since 2010, what has happened is it's not just broad-scale shuffling of DNA that is leading to a problem like this. You can even have small chunks of DNA, whereby if they're either missing or you have an extra copy of them, you end up with repeated fetal loss. So a very good example of that could be Dye-George syndrome, what is known as velocardiofacial syndrome. That happens because a very small chunk of DNA on chromosome 22 has gone missing. And it manifests itself with a heart defect in the child. So essentially, the heart isn't developed properly. It's not pumping blood properly. And because of that, this issue occurs. And this is around in mid-2010s when this technology started to be used in clinical practice. And today, if a couple comes with repeated fetal loss or an issue of repeated fetal loss, you would actually start with microarray. You don't start with chromosome, you start with this because it explains nearly 30% of couples having this issue. Now, very recently, in the past 3 years, in fact, sequencing, what we call as NGS or next generation sequencing, has started to be used in these couples. And we are now realizing that even a single letter difference in the DNA can also lead to an issue like this. So there are diseases whereby if only one copy of the DNA has the single letter difference, it can lead to very serious limb deformities. And because of that, the child can't survive. It's lethal. It's genetically lethal. So in these couples, by identifying which technologies work best in which scenario, it can help in guiding what sort of reproductive options are available for them. Should they go for natural pregnancy? Should they go for IVF? Should they go for donor program? Etc., etc., etc. So once you know where the problem lies, you can start to provide the right sort of reproductive options to them.
But you've mentioned how there's a missing piece. Isn't this where, forgive my ignorance on the subject matter, but isn't this where gene editing comes into play?
So this is a bit of a controversial question that you just opened. So gene editing, it sounds like very simple. It's everything is sorted, but it's not. Gene editing in some sense is precise and imprecise at the same time. So if I were to edit DNA of a bacteria and I want to edit a very particular part of its DNA, it will go and cut it. But at the same time, it will also miss target. It will also try and cut other parts of the DNA that I didn't want it to cut. Okay. But it will do that. That is why it is unethical and banned at the same time to be used on human cells as of now. Yeah. You can't do it. There's only one condition where genetic engineering is being used. It's what is known as CAR-T cell therapy. So this is where you have blood cancers, your leukemias and lymphomas. And what this therapy does is it takes your white blood cells, specifically your T cells, it engineers them to fight back your cancerous cells. And it works very, very well. So in India, we now have a CAR-T cell therapy that costs 1/10 of what it costs in the US. But it essentially uses genetic engineering for treatment purposes. But you can't inherently change a person's DNA from the get-go.
But when I brought up the issue of gene editing, it wasn't about changing the DNA, but I was actually addressing more of the missing parts.
Yeah.
So if they are missing parts, wouldn't that, obviously legally speaking, I am from the field of law, but legally speaking, yes, it might be illegal, but at the same time, you did mention there are places where it's permissible for treatment purposes.
That's correct. So there are some diseases whereby you're not doing a genetic change per se in the person's DNA, but you're supplicating that missing piece. So a very good example for that would be spinal muscular atrophy. You know that one particular piece of DNA is missing. It's what is known as SMN1 gene that's completely missing. So what you're doing is you're developing this little capsule that carries that piece of DNA. You put it in the cell and it expresses the protein that is missing, and it helps to alleviate a lot of symptoms. But you can't change a person's DNA inherently. You can supplicate it.
Okay. But I think we're basically saying the same thing, because honestly, there isn't much I would like to change about myself as a person, but there are aspects of a person in which you know that, okay, this deformity might be based on something that went wrong in your DNA. So that supplication, I guess that basically pretty much answers what I was asking.
It does work, but not in all genetic diseases. There are diseases whereby your DNA is absolutely intact. You have 2 copies of DNA, everything looks shape. It's just which part of the DNA has come from which parent decides whether you have the disease or not. So there are 2 diseases called Prader-Willi and Angelman syndrome. They're completely separate from each other. The only difference is both pieces of DNA has either come from the father or come from the mother. Yeah. So in that case, how do you supplicate it? You can't.
Science is complicated, I guess.
Genetics is ridiculously complicated, is one thing we have realized.
I guess that's not a simple way to go about it. But since we're on the topic of inheritance, especially when it comes to DNA or genes, cancer is or can be inherited, I guess, through genetics. But then the question now comes, or rather it boils down to, how can individuals kind of like protect themselves or like prevent cancer from being passed down to them from their parents?
Okay, so to answer your question whether cancer is heritable, I'll refer you to Angelina Jolie. So way back in 2013, she created a bombshell whereby she showed that she has a mutation in a gene called BRCA1, which means she has a lifetime risk of 80% of developing either breast or ovarian cancer. And that happens because she inherited that faulty copy from one of her parents. So she went for what is known as mastectomy. That's removal of breast, removal of ovaries, and removal of endometrium. And because of that, her risk was reduced quite substantially. But it's quite a serious thing to do to have that sort of intervention. And how shall I say, that kind of fueled the work that was happening on hereditary cancer anyways. In fact, one of my biggest piece of research work happens on the most common hereditary cancer syndrome known as Lynch syndrome, or previously it was known as HNPCC. Essentially, anybody who inherits faulty copies of these genes have up to 70% lifetime risk of developing cancers of the colon, small intestine, endometrium, ovarian, stomach, liver, pancreas, esophagus.
Okay.
Not only that, it is as common as 1 in every 300 people in the population worldwide. That means in India alone, there are close to 47 lakh people with this disease, but because this disease hasn't captured the public's imagination right now, less than 10% of them are known to the medical services. And this issue is not just of India, by the way. In the UK, the statistics are equally stark. The same goes for the US or any other Western country you can think about.
Okay.
So, in Lynch syndrome, way back in 1990, we started working on a trial known as CAP2, CAPP2. The idea was that people who, there were 1,000 patients who had Lynch syndrome but hadn't developed cancer at that point. Half of them were given aspirin, a blood thinner.
Yeah.
And half of them were given placebo, a dummy tablet. They were given this intervention for 2 years, and then they were followed on for 20 years just to see how many of them ended up developing cancer for the next 20 years. So in 2020, we finally did all the number crunching, and we showed that people who were given aspirin had up to 50% reduction in risk of developing cancer compared to people who were given placebo. Based on that, in the UK that very same year, the guideline came out saying that anybody who is a Lynch syndrome carrier, who hasn't had cancer yet, can be given low-dose aspirin. And I'm very happy to say, last year, Indian guidelines came out saying exactly the same. That you can give low-dose aspirin. Now remember, aspirin costs as little as 30 rupees a month. So you're talking about something that costs equivalent to peanuts to reduce $1. That's 30 cents. You can reduce your risk of developing cancer by half. The only medical intervention that works as good as this is what is known as colonoscopy. So essentially, you take a bit of you, so there's a camera on top, and you essentially screen your entire colon. And if you do find a polyp, that's the early type of cancer, you can nip it, and here you go. But you don't require such a heavy intervention like that.
That doesn't sound pleasant.
It doesn't sound, no, it's not pleasant at all. I can tell you that actually. The second part of that story was that in CAP2 trial, because it was a 2x2 factorial trial, there were other 1,000 patients. Half of them were given resistant starch. So this is equivalent to you having 2 slightly unripe bananas a day, and the other half were given placebo. Again, they were followed up for 20 years. And in 2022, we finally did all the number crunching, and we showed that people who were given resistant starch, they had 50% reduction risk of developing upper GI cancer. So you're talking about cancers of the liver, stomach, and pancreas. Now, why this is important? Because these are the hardest cancers to identify. You generally identify them at stage 3, right? So very late stage at this point.
Yeah.
They're very hard to treat because, well, the only way you can go through them is either surgery, or you have to do endoscopy from the top. And number 3, they're highly deadly, because all your major blood circulatory system goes through there. So it's very easy for cancer to move from the primary side to other parts of the body.
Yes.
So if you're able to reduce your risk of cancer by half just by taking 2 slightly unripe bananas a day, now that is a trade-off I'm willing to do.
Sure.
Right?
Yeah.
So fiber actually turns out is a very big component that is slowly diminishing from our diet. And it's something as simple as a diet that is rich in fiber helps in reducing your risk of cancer in these hereditary cancers.
Okay. I think this is probably going to be the most important question I've asked so far. And this is going to relay more on the one, you've mentioned how certain pieces of your DNA missing can lead to these things. So one, how can we check for that?
Okay.
And secondly, how can we prevent passing on? Because like you've mentioned before, it's you're getting a copy from your mom and your dad. But then how can we as individuals now prevent passing on these damaged pieces to...
Okay. So let's start with identifying these patients with Lynch syndrome. So generally, any patient that comes to the clinic with colorectal cancer, or bowel cancer, that's called, nearly 1 in 6 of them would have something known as microsatellite instability. Essentially, the spell checker mechanism, they're defective. So if the mechanism is defective, there's a very high probability that you have Lynch syndrome. So you do a very simple genetic test from the blood, and you identify whether that you really do carry a mutation in those spell checker genes, what are also known as mismatched repair genes. If you do have that mutation, you now know that you're a Lynch syndrome carrier, and you will have cancer not just once, but throughout your entire lifetime. So we can start to prevent cancers in you. We can do that sort of intervention. But if you have kids, we can start to screen your entire family. So your brothers, sisters, your kids, your parents, and if your parents are also positive, which in most cases they will be, then their siblings as well, your cousins. You essentially start to screen that entire family to recognize which one of them are carriers who haven't even developed cancer yet, and you can start giving them these simple interventions to reduce the risk of cancer. Now, as far as reducing the risk of passing on the faulty copy, there are now multiple ways to do that. So whilst the child is in the womb, you can do what is known as prenatal screening to see whether the child has indeed inherited faulty copy. Now, whether to continue with the pregnancy or abort the pregnancy, that remains a matter of debate, because inherently you can't edit the child's DNA. The only thing you do know for sure is that child is going to have high risk of cancer if that faulty piece of DNA has come through. But you can tell the family in advance to ensure that they take these interventions from a very young age.
Yeah.
You have the safeguards in place. That is what healthcare is about. Healthcare shouldn't be about treatment all the time. Healthcare should be about prevention, because it's far easier to prevent than to treat.
Yeah, okay, that's a lot of information to digest in just one session. But then again, I believe that Paru University is very much interested in this kind of research. And again, we would like to know, what are the possibilities of collaborations, especially with you and people in your field, in order to kind of like advance even our own research in order to...
So essentially all the research that we have touched upon today, they haven't happened in silos. They've happened because of either clinical collaborations or research collaborations. And these are not just based in India, they happen throughout the world all the time. The time of silos are gone. So anytime a research collaboration happens, what we are trying to do is we are trying to bring our respective strengths to the table to try and tackle that very simple problem. So in that sense, the Institute always remains very much open to forging these collaborations, because that is how we are able to push the envelope of science a little bit more than we alone can by ourselves.
Well, I honestly hope that we can, and we will see more of you in future, especially in projects such as these. So thank you very much for being with us today, and it was an absolute pleasure having you.
Pleasure, sir. Thank you. Nice talking to you. Thank you.
My pleasure.